Hey there, I'm Rob Fields. I'm the Chief Population Health Officer at Mount Sinai Health System, and I'm here with my colleague, Sidney Hankerson. We're here at the Aspen Ideas Festival. How's it going, Sidney?
Having a great time, Rob.
Yeah?
Yeah, really happy to be here and learning about really wonderful ideas.
So we had a session earlier today talking a little bit about some of your work and the collective work of Mount Sinai regarding communities and how we think that impacts outcomes and total cost of care. Tell us a little bit about what you're working on and what you're hoping to communicate here at the festival.
Yeah, sure. So my work is really rooted in principles of community partnered research, where we partner equitably with community stakeholders to try to solve problems that matter to the community. And as a psychiatrist, I'm really focused on reducing racial disparities in depression treatment. And so we've partnered with over 50 churches in Manhattan.
Wow.
And created this program to train community health workers recruited from these churches who will be able to go out into the community, screen people for depression, provide brief counseling, and then connect them to treatment.
Right.
And then importantly, connect them to social services.
Yeah.
So we're really excited about this program and really excited to learn about your work with community health workers and all the innovation Sinai is doing in that space.
Yeah, I mean, I think one of the things that we discussed during the session is thinking about how we involve communities, right? And upstream drivers, you had mentioned, our zip code determines a lot more about our outcomes than our genetic code, as we often discuss. And thinking about the role of churches, and I know we work with schools in some of our projects, why these institutions, as opposed to popping a tent somewhere in a disadvantaged community, why you use the community like this?
Yeah, so churches certainly have historical significance
Right.
in the Black community, and especially as it relates to mental health. More people in the U.S., when they first are having a mental health problem, they go get care from a pastor, more likely than get care from a psychiatrist or PCP like you or me.
Right.
And so especially in the Black community, our pastors are really frontline mental health professionals. And so that's why we've decided to partner with pastors, because it's kind of natural places that people get emotional support.
Yeah, that makes a ton of sense. This seems kind of intuitive, right? Like that we would think about going where people are and trying to impact care there. Why doesn't it happen already, do you think?
I think because the way our healthcare system is structured, right? It's a fee-for-service model. People get reimbursed for direct services, and so I think we're now trying to kind of change the dynamic and really go where people are and try to meet people where they are and provide services in their settings.
Yeah. We're often thinking, we talked about it during the session, but we think about widgets of healthcare. We're kind of fancy health service factories.
Right.
So our widget is a colonoscopy, an operation, all these procedures, and we're incentivized to do a lot of them, and we do them really well. But adding all those things together don't equate to better health,
Right.
ultimately, right? What's next for you? Besides, I know you work on major depression. Do you think there are other roles and certainly in mental health, for these kinds of interventions? Or?
Absolutely. So we also have a grant looking at opioid overdoses.
Oh, interesting.
So kind of a community-based project to provide naloxone and reduce stigma. We know that stigma is a huge barrier for folks getting mental health and especially drug use care. And so we're partnering with communities to create a video where someone will share their story of having a substance use problem, getting treatment, and what that process was like, and embedding that within a naloxone training program, and acknowledging some of the historical factors that have contributed to disparities in drug use, right?
Right.
Like distrust with the police, certainly disparities with cocaine back in the day. And so acknowledging some of those things and then trying to partner with communities to implement these programs.
That sounds amazing. And one of the things that came up, because you're talking about lots of different resources, right? It's not just the pastors, it's all sorts of other community members, is the staffing and workforce issues we face in healthcare in the traditional sense. We're losing nurses, we're losing physicians, and we talked about how to enable other professionals. We talked about community health workers, but there are others, right? There are even just using someone's own family members, for example, as support systems. It is going to require, right, a rethinking of the labor force in healthcare. You talked about doulas, right, in the conversation as well. How hard is it to train up, you think, community members to kind of work on some of these projects, at least in the mental health space?
It's really challenging. So our community health workers go through an 8-week training program that's really based off of the CDC model for training community health workers. And then we provide them with 4 more weeks of training specifically for mental health programs.
Oh, wow. Okay.
With a real focus on trauma. And so what has come up as we've really had these folks out in the field is that they're dealing with a lot of secondary trauma. They're dealing with the challenge of hearing folks in their community dealing with loss of loved ones from COVID, dealing with folks, secondary trauma from the Buffalo shooting. And so we've really had to put structures in place to support their own mental health,
right,
and reduce their own stigma, because there's still stigma, significant stigma in those communities.
Yeah.
So those are the 2 things that we've really had to do.
That sounds amazing. And as we think about the main goals that we always talk about sustainability, and I know that's something we'll continue to work on, is how we think about the projects you're working on and that we're working on the pop health side, and hopefully more projects together, how we sustain those really with the redistribution of funds. I know something we feel strongly about and trying to work on. So glad to be here with you, man. And it's a good session today. So appreciate the time. Appreciate the work.
My pleasure. No, thank you.
And check us out on social media, and hope if you have feedback or thoughts or contributions to some of our projects, I'm sure you can contact us. So thanks for taking the time.